Hi, everybody. This is David Nevins for Citybiz List, and welcome to our program today. And our guest today is Dr. Scott Rifkin. So officially, Scott is the executive chairman and founder of both Real-Time Medical Systems and Provider Partners Health Plan. However, I think it's best to maybe just introduce you, Scott, as a healthcare visionary, healthcare entrepreneur, physician. Welcome to our program, Scott.
Dave, thank you. Appreciate being here.
So Scott, given your introduction there, tell us a little bit about what you're up to these days, the companies you're running, and what it is that they do and hope to accomplish.
Sure. Happy to do that. So the background is I'm a primary care physician, practiced for many years, and realized that there were some huge problems in healthcare. And I can't fix them all, and nobody individually can fix them all. But I sort of got pulled into looking at how to improve the care in nursing homes. And many years ago, I was the state of Maryland's doc that sort of got parachuted into troubled buildings to fix those buildings, to fix the medical care in them. And clearly, we are not doing the job that we could be doing for our seniors and our chronically ill that live in skilled nursing centers. And so my area that I've worked on all these years has been, how do we improve that care? And how do we do it in a way that financially society can afford to do it? You know, look, you could throw 100 more people employed in each nursing home and got really high quality care. But the reality is government and taxpayers aren't willing to pay for that. And so you got to come up with better ways to do it. And then you throw on top of that other problems the industry has that, Dave, we can talk about more if you're interested. But the bottom line is we aren't, for the most part, providing the level of care in nursing centers that we could. 60 to 70% of the hospital admissions that are generated by nursing home patients are avoidable. Think about that a minute. 60 to 70% are avoidable. And they're avoidable for really simple reasons. I'll give you an example. You know, nursing homes are not driven by doctors. They're driven by nursing aides. Most of the employees that take care of patients in a nursing home are nursing aides. You've got, in a nursing home, you might have 50 or 60 nursing aides. You might have one registered nurse. You might have two licensed practical nurses. And you have a medical director or a physician who sees the patient once a month, if you're lucky. So the hands-on care is all driven by the nursing aides. The problem is the nursing aides are not particularly educated. They're well-meaning people. They're not highly paid. They care for the most part, but they have very difficult lives, a lot of them. And they just don't notice things that make those admissions avoidable. And I'll give you a quick example, Dave. The patient who hasn't had a bowel movement in 3 days. Okay, it's hard to talk about that as friendly lunch conversation, but in a senior who's on multiple meds, maybe they just had hip replacement surgery, maybe they're confined to a bed or a wheelchair, maybe they're on narcotics that for pain that reduces their ability to have that bowel movement. If they don't have it, they get septic. They get impacted and backed up and septic and end up in an ICU or die from it. Happens all the time in nursing homes. And it's completely avoidable with 50 cents worth of a stool softener. But you got to know when to give it. You got to know when. And so we're missing those opportunities. I'll give you another example. Patient with a history of congestive heart failure, very common in the nursing homes. That patient starts gaining weight, but nobody notices because they're just understaffed and overbusy. And they miss the opportunity to treat that patient with a little bit of diuretic for 3 days and avoid the hospitalization. They wait until that patient's short of breath or having chest pain from it, and then they get admitted, and sometimes they die from it. And so those are preventable admissions. And they're preventable with lots of staff, or they're preventable with the area that we've really missed the opportunity on so far, which is data mining. Okay. And what I mean by that is there's a medical record, and that nursing aide and those nurses and even the doctors and the therapists and everybody else who touches that patient are all putting information into that chart every single day. The problem is nobody's using that information. It was mandated that you have them. And the fact that that patient did or didn't have the bowel movement, or the fact that that patient gained weight with a history of heart failure is all in there. But to manually expect a nursing aide making $14, $15 an hour, or to manually expect an RN or LPN who has 150 patients to take care of to notice is a difficult thing. But we have modern data tools today to find that stuff. And it's very findable. And so what one of our companies does, and that's real-time medical, is to go into the medical record, read the information in the medical record every day, find those interventional moments where if you intervene, you're going to prevent a hospital admission, and then point that information out by push message, by phone call, by platform, all kinds of different ways, mobile app, that these patients in your nursing homes, the director of nursing or charge nurse looks at this. These patients have these interventional moments. And here's the approved national standard interventions for those issues. It seems pretty simple. It's not rocket science. It's not artificial intelligence, because I don't know what the heck that is. It's not machine learning, because I definitely don't know what that is. It's simply asking the data specific questions, which were the joint knowledge of a bunch of nurses and doctors we put together. And we ask a couple of hundred questions a day, and we find those interventional moments. We have hundreds of them.
Yeah, no, so this is fascinating. So let me just make sure I and our viewers understand this. And by the way, I will add that we've probably done close to 100 of these CEO business interviews, and I'm pretty sure this is the first time we've been speaking about bowel movement. So congratulations to you on that.
I consider that quite a compliment, so thank you.
And it was intended as that, for sure. So for this to work, and your company is doing this, does it already have to know how often a bowel movement in an elderly individual should occur, or does it need for someone to ask if this person has, gone to the bathroom? Be a little more specific if you don't.
So if you make work for the nursing staff, there have been lots of solutions to this 60 to 70% of patients that go to the hospital that shouldn't. There have been lots of solutions, and they academically all work. If you throw lots of people, lots of nurse practitioners, lots of doctors, lots of time, you can avoid those things. But the reality is most nursing centers don't have the money to do that. The state and federal government don't pay for nursing care at that level. And so if you make work for the nursing staff, it isn't going to happen. So what you want to do is take information they're putting in the chart routinely anyway. So they're putting the information about the weight. They're putting the information about blood pressure. They're putting in information about how somebody eats or drinks, or their activities of daily living. Can they take care of themselves? Or how they did in therapy, or have they had a bowel movement? And I'm trying to get the record for how many times I can say that in one comment.
I think you've already won, just so you know.
Sure, it's an unbeatable record. It's like a record. But if you take the data they're already using, it's the old enemy of the good is the perfect. It would be good to reduce admissions 60%. Perfect might be 70%. I mean, some people are still going to have a heart attack and end up in the ICU. Perfect might be 70%, but if you can never get people to fund perfect, let's go for the really good. And that's that 60% reduction, which I think is very achievable, and we've done in a lot of places. By finding those interventional moments, pointing them out to the right person, and then recommending what the intervention ought to be. And when you do that sort of thing, it really works. So we've done that now, we're in 1,200 nursing centers doing this today. The quality improvement organizations, which are funded by CMS. CMS is Medicare and Medicaid, the full funding source. Right. So they pay for almost all the nursing home care in this country, virtually like 95% of it between those two programs. They pay these quality improvement organizations to help nursing centers and other Medicare providers improve their quality. The four biggest in the country have added us into their budgets for this year. So it's growing very nicely. They're going to bring another 600, 700, 800 nursing centers into the program. But we're in 1,200 today in 45 states, and it's really all over the country, with the biggest states being Maryland, Pennsylvania, Ohio, Illinois, Texas, Florida, and those are the big states. but it's growing rapidly, and it's growing because of something called value-based care that we'll talk about in a minute. Okay, but the bottom line is, so I'll give you a couple examples. We have a big affordable care organization, okay, ACE and ACO, and that organization uses our system and uses our nurses that look at the data. And they've reduced their admissions. This is in Southern Pennsylvania. They've reduced their admissions by almost 65% from baseline. And they've maintained that now for 3.5 years. It's not a fluke, it's the real thing. We have another group associated with a major university in North Carolina that may or may not have been in the national championship for some the last week or so. So there's two that could have qualified for that.
That's right. So it's a 50-50 guess, right?
I haven't spilled any beans here, but they're associated with a big ACO, and they've reduced admissions about 60%. It's amazing what can be done when there's a cooperative effort like that. The nursing centers like it because they're responsible for those things. Patients sue them over those things. Regulators fine them over things that go wrong in the nursing home. So they love that help. They just haven't had it before. And there's no reason we couldn't be doing this nationally. For about the amount that we spent in one day on the pandemic, you could do this nationally. You could have a system for 40, 50 million bucks a year for the whole country. It costs 500 to 1,000 bucks a building to do this per month. It's not expensive to do. So it's very doable. The software is out there. The call centers are out there that work with this stuff. And it's a shame if we don't do it.
Yeah, Scott, I know you're, as anyone can tell, quite passionate about providing better healthcare for the vulnerable and for elderly patients. Let me just shift gears a little bit. There going to be in the coming years a lot more baby boomers who are going to need healthcare, and they're going to want access to high quality healthcare. They're going to be in the senior population. Talk to me a little bit about that and how your work is impacting that opportunity as well.
Right. So this is, again, the intersection with something called value-based care. I mean, there's no question that the number of seniors that are going to need nursing home care is only going up. And there's also no question that the ability of government to pay for it is limited. And on a cost as a part of our GDP is going to go down up. Because it's just the reality of government and government debt and all this sort of thing. It's not a political statement. It's just what's going to happen. And so it's going to get tougher and tougher to take care of these patients in a suitable way. Now, there are those that argue all these patients should be in home care and in assisted living. And I don't disagree that some of them should be. But there's a segment of that population that needs the nursing care that a nursing home can provide. And so the real question is, how do we make nursing homes better for the patient who needs them for a short term? They broke their hip, they live on their own, they could take care of themselves after a week or two of therapy and they're going to go home. How do we make that a safe environment for them? And the other is, how do we make it a safe environment for the long-term care patient? The patient who has Alzheimer's and has nobody to take care of them. Because truthfully, the cost in a nursing center is way lower than the cost in home care. Give somebody 7-day-a-week, 24-hour-a-day home care is 2 or 3 times the cost of a nursing center. It's not even close. So as much as we want to do that societally, it's probably not going to happen. Okay. So the real question is, how do we make those nursing facilities better? Now, the other thing that's going on is a move towards value-based care. And that's a term that the folks at the Centers for Medicare and Medicaid Services, CMS, talks about a lot. And what it really means is having somebody be responsible for the quality of care. So what they've done is they've created lots of different programs. One is managed care Medicare. Every night you turn on the news, there's some 1960s TV star, who's or Joe Namath or somebody else touting, an Advantage plan, which is managed care Medicare.
Right.
And by the way, those are great programs. You get more for your dollar as a Medicare patient. What they really say is to a private insurance entity, we're going to give you the lump sum of dollars we spend. You are now responsible for spending them. If you can lower the cost of care and still maintain quality, then you get to keep those dollars and the savings. And if you can, and they, by the way, you're mandated to spend 85 cents of every dollar under Obamacare, under the act, on the actual care of the patient. So the profits of the insurers are limited. Okay, but having said that, if they overspend, they've got to then send a check to the government. And those programs are just growing rapidly all over the country. And I think the stated goal of CMS is to get virtually every patient into one of those programs by 2030. And the reason they do that is the studies of it that have been done show that outcomes are better. Those companies have a huge incentive to do preventive care. They have a huge incentive to put in place things that Medicare has always hesitated to pay for. And the reason Medicare hates to pay for new things is because once you approve a new payment and nobody's watching how much it gets used, it gets abused. So
Scott, no, I'm sorry to interrupt. We only have a couple minutes left, and I really just want you to talk about the future of your businesses and kind of next steps. And I know also you've been helpful in the state-of-the-art monitoring with regard to COVID issues, but literally in 2 minutes, if you don't mind, just sum it up and tell us, where we're going to find you and your businesses, and what your space is going to be, and what your vision is for this.
So it's all about the data. It's all about the data. You can walk into a bank halfway across the world and get dollars out, but you can't get your medical information across the street half the time. And it's all about having the data at the fingertips of people that can see its impact. So you need data mining, you need analytics attached to the data mining. And so our business is just growing like crazy all over the country. We're starting to do services for hospitals and ACOs and insurance companies and Advantage plans and groups of nursing home operators that just want to do a better job. And then we also have the other company, and you mentioned at the beginning, Provider Partners Health Plan, that then works with some of these providers, taking that risk with CMS, whether to run an Advantage plan called a iSNP in the nursing homes, or to do other value-based programs that CMS is promoting. So the future is really managed care Medicare or value-based Medicare that protects patients' outcomes, measures them, makes sure that they're being improved, and then creates the incentives. Part of the problem with Medicare is there's no incentives on outcome, and there's no incentives on expense. And so you create these new parameters on private parties, to improve quality and control the cost, and they'll all perform to the test. If they know that the formula to earn more money as an organization is to make sure that Mrs. Jones lives a longer and healthier life, they will figure out how to do that. And if you don't put in the incentives, I hate to say it, but we'll keep doing business the way we always have. Everybody will figure out how to increase their piece of the pie, but nobody will be that concerned about outcomes.
And I know, Scott, your mission is ultimately just to provide better health care for the vulnerable and for the elderly. And I know your companies have been working to move that forward.
Yeah, we've been really fortunate to be able to do that. It's interesting. We have a team of about 65, 70 folks. About 20 of them are software engineers. And then the rest are doctors and nurses and people with healthcare experience. And when I talk to them on our used to be in person, but now our conference calls and all the such, we don't talk about financial stuff because that'll take care of itself. We talk about is how lucky we all are to be able to help improve the care of the most vulnerable people in society. And we're having that effect. I mean, we're now caring for about 200,000 people around the country, adding to their care. And if we calculated how many additional years of life, how many additional years of quality life, it would be in the millions. And it's really a wonderful thing to be able to look in the mirror every morning and see that and see those outcomes. And that's why the team is so driven to do this stuff. It's really a nice thing.
Scott, tell me how this program will be seen by business leaders, civic leaders, other entrepreneurs. How does someone contact you or your companies?
Sure, be happy to talk. The websites are, the companies are PPHP, Provider Partners Health Plan. We have a website. It's Real Time Medical Systems. I think it's realtimemed.com, if I remember right. Or they can contact me. My email address. It's Scott, S-C-O-T-T, Rifkin, R-I-F-K-I-N, M-D, @gmail.com. Happy to talk to anybody who has an interest in providing better care for patients.
That's great, Scott. I can't let you go without people know you as a physician, healthcare entrepreneur. What are you growing in your greenhouse these days at home? I know you also have a green thumb, if I'm not mistaken.
Well, I'm so lucky to be able to do that. I have a nice little greenhouse, and right now I have fresh strawberries. I have, what have I got? I got strawberries. I have peppers in it soon, and I just planted corn in the greenhouse, which is about 3 weeks earlier than you can plant it outside. So by July 15th, July 1st, I should have nice fresh sweet corn.
Okay, corn, strawberries, and peppers.
Yeah,
An interesting combination. You can make your own salad for sure.
Absolutely.
Hey, Scott, thank you so much for joining us. I mean, truly, this has been fascinating, and I think we'll want to do it again in relatively short order. We appreciate your time.
My pleasure. Thank you so much, David. Bye-bye.
This is, so long, Scott. This is David Nevins for Citybiz List. Thank you for joining us for this fascinating interview today. Appreciate your time.